All right. Well, I am so excited for this episode. This is an episode we have been planning for months. So let me give you guys just a little back because you're getting the hot scoop here on your Anxiety Toolkit podcast. About a year ago, my amazing friend Chris Tronsden and I had a conversation about how I would love for him to join us at CBT school to train our clinicians and people who are suffering with BDD, Body Dysmorphic Disorder. Chris, I consider to be an expert, probably the best clinician I would say in the world in this area, an amazing advocate for folks with BDD. And he said yes. So for those of you who don't know, I have Chris here with me. Thank you so much, Chris, for being here.
Yes, thank you so much. That was the sweetest intro, by the way. Thank you so much. I was just gonna say, I didn't want to interrupt you, but no, I was so honored. This is your baby. Like CBT school is like Kimberly Quinlan, right? It's your baby. You've trained so many clinicians, so many people with the disorders have gotten help. So when you asked me, I was extremely honored and beyond excited.
Yes, I was too. And so we are here to talk about BDD, but we're also here to share that a few months ago, Chris and I sat down in a hotel room and with all the cameras and all the lights and with a raging festival going on next door and recorded for like what felt like days and days, like 12-hour days. We did not stop and we did get those courses created. Now we're still finishing up the suffering course, so you will be able to get that, but the clinician's BDD toolkit is out. You are welcome to check it out if you're a clinician. And for those who are sufferers, you can also access Chris teaching you exactly the steps that he takes his clients through in treating BDD. So it is gold. You can go over to CBT school to check it out. But today we have Chris wanting to really get you familiar with the topic and get really excited. We're talking about what body dysmorphic disorder is, what actually helps, and what makes it worse. So thank you, Chris, for being here. It's an honor.
Oh, well, thank you so much for having me. I'm beyond excited, obviously, to be on the podcast, but more so just to share this. I know clinicians all the time are asking me questions about it, wanting to consult with me, and BDD is a widely misunderstood disorder. So I'm just excited as somebody who has BDD, just that more and more clinicians are going to be accessing the course and being able to start treating people. There's a lot of people with BDD and not enough clinicians that know how to treat it. So I'm really excited about this course.
Yeah. And I think what's so exciting too is I think that, and we're going to talk about this in future episodes too, but I think that people often treat BDD as if it's just body image issues. And I want to talk to you about that. So first of all, tell me off the bat, what is BDD?
Yeah, so BDD, which stands for Body Dysmorphic Disorder, it's classified currently under an OCD-related disorder. So we have the disorders like BFRBs, obviously like trichotillomania, excoriation disorder known as skin picking. You have hoarding disorder, and then you have body dysmorphic disorder. Now, body dysmorphic disorder is a mental health condition where an individual becomes very fixated on a flaw or flaws on their appearance. They feel like they're unsightly, they feel like they're deformed, and when they look in the mirror, they feel like absolutely ugly, but also even more than that, they feel like they have this feature. It could be the nose, the eyes, the ears, typically it's neck up, but they have a fixation on a perceived flaw. And because of that flaw, they spend at least an hour a day or more through mental and behavioral compulsions, sometimes camouflaging, trying to hide the features. It could be through makeup, wearing a hat if they feel like they're losing their hair, through covering with clothing, or sometimes more drastic measures like self-plastic surgery, which is very scary, or plastic surgery. And so the reason we highlight that word perceived is I think the most difficult part about having this condition is that friends, family, and everyone looking at the person doesn't see that flaw. They can go to doctors, they can get reassurance from other people and continuously getting told, no, your skin looks fine or your nose isn't big, but this person sees it differently. And so that's really kind of the component of the disorder, this difference in what they view, this problem with perception.
Yeah, absolutely. And what I want you to share about here is why is BDD under the category of an obsessive compulsive related condition? What is it about them? And I know we will talk about this in a future episode, but I just wanted to clarify, why is it under that umbrella?
Yeah, there's two real reasons. The first reason is because of Dr. Catherine Phillips, someone who I admire a lot, who wrote The Broken Mirror, the first real book on BDD. She saw a lot of similarities in the research as obsessive compulsive disorder and also found that there was a high co-occurring rate of people with OCD and people with BDD. She also strategically knew that if it was under the OCD related categories, that it would get more research, more attention for people suffering. But there's similar components we see in the brain, but mainly people with BDD also have that very obsessive nature. They get fixated on that body part. They can spend hours, sometimes 8 hours a day till their legs hurt, looking in mirrors, looking at pictures, recording themselves, watching it back. So they have that obsessive nature, and then the compulsions come in. So similar to people with OCD who feel the need to drive back around the block or pray, somebody with BDD is feeling like they need to continue to camouflage or research different procedures or skin products or ways to cover it up. We see the same things as reassurance seeking, the same loss of quality of life. So there's so many similarities. There's some big differences, but there's a lot of similarities with the two conditions and a high co-occurring rate. Often, if somebody has BDD, they're more likely to have OCD than any other condition.
Right. Often when I have a new client with BDD, sometimes their family members may perceive the person with BDD as being too self-focused or, very overly concerned with their looks, as if it's sort of like a personality trait per se, or a weakness on their behalf. What are your thoughts, and what do you tell clients and loved ones of people with BDD about that?
Well, I think that's sadly one of the most misunderstood elements of the condition. A lot of people think that people with BDD are vain, are very self-focused, and that's not it at all. Some people's presentation of BDD is actually a lot of isolation and hiding, but some people's presentation with BDD is sharing a lot of pictures, dating a lot, getting into a lot of intimate relationships because they want that reassurance that people see them as equal. So typically people with body dysmorphic disorder find themselves to be unsightly, unattractive, and almost like outsiders in our society. And they just desperately want some kind of relief from the fixation on the body part, but also some reassurance from others that they belong, that they're good looking enough, and they're going to have access to the same things most people have, like friendships, love, family, children. So people with BDD actually think very low of themselves, have low self-esteem, and really just want to be accepted. Unfortunately, because of the compulsive nature of it and the fixation on that appearance, multiple dermatologist appointments, multiple plastic surgery assessments, others on the outside who don't understand the condition assume it's because they want to look great, they want to be the hottest in the world, and that they're focused on their looks. But it's so far from vanity.
Yeah. It's funny. We always kind of make jokes or roll our eyes at when people misunderstand OCD. Just the other day, I was talking to someone in my office, and they were saying, everyone has OCD at this point. And I did my best to educate them, and they kind of blew it off, right? But I think what I said was people with OCD are seriously suffering. They don't just want order. The reason I tell that story is I think we sometimes think people with BDD are looking in the mirror, just trying to look better and trying to, because culture is constantly telling us to be taller, shorter, be different, be whatever. It's constantly telling us to change and be something else. But BDD is incredibly painful. It's not a joyful preoccupation with your body. And I wonder if you could maybe share your own experience or the experience of a client, what you have noticed about folks with BDD.
Yeah, I mean, you hit the nail on the head. And one thing I always try to remind people is the last D in the disorder stands for disorder. I mean, disorder means a real loss of quality of life, whether that's general happiness, social relationships, work relationships. And so people with BDD are really suffering. And I want everyone to think that the way we look is always elevated in every culture. There's a whole billion-dollar industry and improvement in looks. And so this is the first thing people see. There's research that people who look better might make more money at work and get jobs. So if you're kind of the first reaction people get is your appearance, that's the first impression. If somebody has BDD and their brain is telling them that they are so hideous they don't even deserve respect and love, that person doesn't want to go out in the open. And so I know for myself, you were asking about my personal, and then I'll share, just general what I see in clients. But I remember in high school, I was on a sports team, and we spent the night before a tournament, and I had created my own self kind of skin routine of acne products because I thought I had horrible acne, even though every dermatologist was like, here, you have a few pimples, that's it, right? But I'd kind of done research online. I created my whole kind of self routine. And I remember waking up before the other boys, sneaking into the bathroom to do my whole skincare routine, which made me feel human enough to leave the house. And I remember crying while doing it because I'm like, everybody else just woke up. I mean, they're teenage boys. I don't even know if half of them brush their teeth, but they just kind of like got up, threw on maybe some Axe body spray, and we're done. And we went to the tournament. But I had this like hour routine, this struggle. I was so nervous people were going to get up and catch me and all of that. And to me, it was just like I felt like a monster, an outsider who just wanted to be accepted, especially during that time when we're trying to get approval from our peers and from people that we're attracted to. And so that's what I hear from my clients. Now, that was the early signs of my BDD. When I talk to clients who may not get to my office until after they've tried so many different surgeries or camouflaging or research. People are in pain. A lot of them aren't working because being around the public is too difficult. They feel that others are staring them, noticing their flaws and judging it. They're often not in a relationship. A lot of them are living at home. They're going to different dermatological appointments, cosmetic dentists, just trying to get relief because 24/7 in their brain, even sometimes in their dreams, everything is, you look unsightly, people are judging, you look like a monster, you'll never be loved, you'll never be accepted, you're worthless. So I just think that people experiencing BDD are just getting a constant dose of just their brain attacking everything about them. It goes a little deeper than appearance over time. They start to have that core belief that they're not even worthy of love, affection, or attention.
The word that comes to mind for me, and Broken Mirror was the first book I'd ever written on BDD. I was assigned it when I became an intern, working with folks with BDD. And the word that just keeps coming up for me is just that the feeling of disgust about themselves. And, I think there's not a lot more painful than to feel disgust towards yourself. Like that's a horrible, painful, shame-filled experience that folks with BDD are navigating. So I think it is really important that we acknowledge that they're coming to us with that feeling, shame and humiliation, embarrassment. It's so, so painful for them. That's why I love in the course, you really get to the bottom of that and acknowledge that that's where we're meeting the people when they come in, and for sufferers as well.
Yeah, I mean, you hit it on the head. A lot of times people ask me as they navigate from, treating maybe solely OCD and wanting to start treating clients with BDD, or they're getting clients coming to their practice. And I tell them all the time is there's a big difference, is that for most people with OCD is ego dystonic. They have a very clear understanding that these thoughts and these feelings are not that of their own, especially after they get a diagnosis and have some education on the disorder. And so there's a lot of like, I want this thing to stop attacking me. How do I make it go away? BDD is much more ego-syntonic. Like people believe the thoughts. They want to engage in these compulsive behaviors out of desperation just to be able to feel like they belong. But one thing that you nailed is that it's a lot more than anxiety for BDD, which is a huge difference from OCD. There's a lot of shame, just feeling horrible about self. There's a lot of guilt. There's a lot of like onus and blame on certain aspects of their appearance. And sometimes in severe cases, people almost feel an obligation to the public to not even leave their home because they're like, I don't want to force people to feel sorry for my appearance or, look down on me or, make other people feel discomfort, but having to look at my disgusting appearance. So, I mean, just to think that you don't even belong running into a store. So many clients are ordering things delivered to the home just to spare others from seeing them. So that disgust, that shame, that guilt, and that just overall unworthiness that we see in this condition makes it so, so detrimental and disordered.
Yeah. So painful. So painful. Let's start with what makes it worse, and then we'll move on to what makes it better. What are some things that people with BDD do that make it worse? And then maybe we can talk about some treatments that can make it worse as well. So would you share and when we talk about this, I just want everyone to know in no way are we saying you're at fault or you're doing anything wrong. It's a natural response to engage in these sort of traps of the condition. Like it does trick us into doing behaviors maybe that take up a lot of time. So what are some of the things that people do that can make it more difficult or make the disorder stronger?
Yeah, and I'm glad that you put that caveat at the beginning. I want everyone to hear this. Everything you're doing, if you're listening to this with BDD, is your natural response. But unfortunately, it just reinforces the condition. So I'd start with a lot of reassurance seeking. So sometimes it might be with a trusted family member or a loved one. It may also be with your romantic partner. Do my teeth look too big for my face? Does my neck and my jaw not look masculine? Do I have too much body hair? Are my breasts not symmetrical? So asking a lot of questions. And typically that's what I hear from partners, is that their loved one that they're in the, romantic relationship with is just constantly asking for reassurance about looks. And the reason it doesn't work is people with BDD don't believe it. They often dismiss it and think that the person is just pitying them and saying nice things to make them feel better. I would say the second thing is research. You can go on a deep dive. I mean, I know people love Reddit, but I think I just have such a bad taste in my mouth because of everything myself and clients have done on that website to look for stuff for relief. But there's a lot of people posting different things. This makes you look hotter. Online, they have these things called the golden ratio, and people are looking like your eyes have to be this down on your face. And people are, using all these apps to look how symmetrical their face is. And so this just feeds the beast. And so
Yeah.
people with BDD are picking up their phones, and all the people they're following are have something to do with a skincare brand or plastic surgery. Speaking of that, what definitely doesn't make it worse is camouflaging, which soon becomes sort of like a little bit lighter cosmetic work and then heavier cosmetic work. And so what I see in my younger clients, who obviously aren't of age of doing any kind of plastic surgery or fillers or Botox, is they mainly start with camouflage. So,
Yeah.
saying they're cold, so they're wearing a shirt at the pool, or they might cover some like skin imperfections they see that no one else sees with makeup. And then typically over time, that might become fillers and Botox and Sculptra and all these different, chemical peels, bleaching teeth compulsively. And then eventually with people that go untreated with BDD, it typically ends with plastic surgery. And so in the Broken Mirror, and the research is very clear about this, when somebody with BDD seeks out that plastic surgery, they're almost never happy with it. And in fact, a lot of times it makes them less pleased with that body part. In those rare instances where someone does like the plastic surgery, it's typically short-lived. They are either going to start seeking more plastic surgery for relief, or they don't like the balance of their face now after the plastic surgery, or they were expecting to be super happy because their appearance was fixed, and then they're not and fall into a depression. So that's why we always say, whether it's plastic surgery or dermatological, interventions, or even just camouflaging, it's actually going to make you feel worse in the long term.
Right. And I'd like to just pause on that and dig a little deeper, because this is a question I often, or it's a conversation I often have with clients in terms of to have surgery or not. And I think what's really difficult is folks with BDD maybe see someone on social media. I know I'm thinking of one person in particular right now who they say, I just didn't like my nose. And I knew when I turned 18, I would have surgery. And my nose, they reduced the size, or they did whatever. They took the bridge down or whatever they did. And then I was happy. And so they've seen that this person with BDD has the idea that that's what it's going to take. Does it mean that everyone who's had surgery has BDD? Or what is different about, the surgery of the person who has not got BDD, and it just goes well and they go on to live their life and they don't even really think about their nose ever again, compared to someone with BDD?
Yeah, I think the difficult thing is we are in a culture where plastic surgery can be celebrated. People will post their afters and the comments will say, wow, you look so much better. So I think the hard thing is, just like somebody who may have, a substance use addiction, they'll go to a bar and they'll think, how come everybody else my age gets to go to a bar and drink, but when I drink, I have a problem with it, right? So we know that there's something different. It's similar to BDD. There are of course, times where people will go and get certain fillers or Botox or enhancements and feel better. The problem with somebody with BDD is they do not see the same thing that everybody else sees, including their surgeon. So what happens is you have two people trying to fix something, but they have two different versions of it. So
Yeah.
the person with BDD is going to see this exaggerated. Let's, talk about a nose. Let's say somebody goes in for a rhinoplasty for a nose job. They walk into the office and they see the nose as big, they see it as wide, they see the bump as over exaggerated in their head, because there's a problem with perception and the way that the brain works with individuals with BDD. Well, the surgeon doesn't have BDD. So the surgeon is looking at it and thinking, one thing clients who have gotten surgery will tell me is that they almost had a argument with their surgeon, because the surgeon is like, I think you're wanting to go too far. But it's because two individuals see way different things. And so how can two people come to a conclusion on a body part when people are seeing it look differently? Now, just like you mentioned, sometimes clients with BDD were bullied or were, did have a feature. I had a client with BDD who wanted to get his ears pinned back and did before he saw me. And he had gotten called Dumbo growing up and his ears stuck out. And, his parents always made a comment. I'm like, people can have BDD and also have body parts or features that maybe other people agree, like, hey, yeah, when you're 18, if you want to get your ears pinned back. But what I explained to him is nobody has ever said anything else about the other features. And in fact, in his case, when he went to talk to the surgeons about getting these things fixed, they kind of turned him away, which is astounding for plastic surgeons. They're typically known for wanting to make money, but they were just like, hey man, like we feel like that's going to be overboard. Like you're going to start to look a little bit odd. So what I told him is like, sometimes people with BDD are more sensitive to appearance features,
Yeah.
want to get things fixed, but that doesn't mean you're going to have that same result and that same feeling around everything else you're doing. So you really have to, what I always tell clients is do the treatment first if you can for at least 3 months with me. So if you do decide to move on with plastic surgery, I can't follow you home and force you not to do something, but my hope is that the treatment helps with some clarity and whatever decision you make won't be as drastic as it would
Yeah.
have been without treatment.
In the courses, we walk through the steps that you take with clients, and it was so cool to watch you talk because it's very, very similar to what we do, is we do a lot of education at the front end because sometimes folks with BDD don't know that their perception may be off, and that's, I think, very helpful for folks for BDD to understand because they believe what they see is real. Can you explain what's going on for them and why their perception is off and how that shows up for folks with BDD?
Absolutely. And you made a good point. I mean, the education for the clinicians listening, education is done much more than any of the categories in the related disorders, including OCD itself. Because I think what's unique about this condition is that people are coming in and you're not their first stop. Typically, it's a family member or a partner or somebody who's intervened and said, you need to get help. Or the person is like, I don't think I have BDD. I just am very stressed about my appearance and want someone to talk to. So the beginning stages are so important, that education phase, to get the client to at least be open, like, hey, maybe it doesn't have anything to do with my appearance. It's that preoccupation that is really causing the distress. So unfortunately, in individuals with BDD, just like all mental health conditions, we know there's something going on in the brain. And so mentor of mine, Dr. Figen Ezeraglu, we were doing a talk together and she said it really well. We're the only people that are never going to see what we really look like. I mean, we'll see a reflection of what we look like, but none of us can go outside of ourselves and see ourselves. So the first problem and the reason why people with BDD see themselves so differently is in the manner of how they see themselves. So one absolutely trademark aspect of BDD is people are looking in mirrors or taking pictures of themselves or videos in a manner that other people don't. So they're getting very close to these mirrors, they're getting zoomed in on these pictures, and they're getting so fixated on these small details. So if somebody, for instance, has a little bit of acne and that's what their BDD is really focusing on, they're looking at themselves in a mirror and they're only seeing the acne. That's what they're focusing on. They're getting extremely close into the mirror. They're only noticing that. And it may only be 2 to 3% of their face, but to them it's 100% because they're not looking at their nose or their eyes. They're not seeing the whole picture. They're just getting very isolated on the part of their face that they don't like. And in this case, the acne. But additionally, there's stuff going on in the brain. So when people are looking at themselves with BDD, what we've found is the part of the brain, the left hemisphere, that usually is utilized for high focus details and very fine information, that is only sort of tapped in for the average person when they're doing something that needs that. If they're hammering wood and they're getting really close on the nail, if they're an artist and they're looking at fine details to paint, their left hemisphere is lit up. But in normal conversation like I'm having with you, the right hemisphere is lit up and they're also looking holistically. Although I'm making eye contact with you, I can see the, outside where it looks pretty and there's grass. I could see that I think it's a shirt or a blanket that's hung up. Like I can see everything, right? That's not how people with BDD are found through research to be looking at themselves. They're getting very zoomed in on fine details. They're getting very interested in the little lines of their face or the fact that this side of the jaw isn't as even, or the fact that they have a little bit of acne right here. And then coupled now with that, getting close in the mirror, staring for hours, all of that comes together. And now the person is focusing on 3% of their appearance and absolutely negating the other 97%. And in their head, they're just a set of acne or a set of like big calves or too small of a waist for a man. I mean, just whatever the fixation is. And so that has to be understood by the client, because if not, they're going to push back and say, I see it in pictures. I see it in the mirror. Don't tell me I'm crazy. I see what I see. It's helping explain through actions, through what's going on in the brain and other factors. We know people with BDD see themselves and perceive themselves differently than the average person does when they talk to them.
So that is so helpful, I think, for folks to hear. And I know, again, it's been so helpful for my clients to understand. Are there any other things that make it worse?
So one of the things that makes the disorder worse, and that people do to make it worse, is that people misread faces in BDD research. So what that means is when they were shown a set of faces that were neutral, people with BDD perceive them as like angry, confused, disgusted. So let's think about that for a second. If I have BDD and I'm going out and I'm misreading everyone's faces, I'm going to see them as being judgmental or disgusted. And then because of my confirmation bias, I'm going to say, oh, see, I just got confirmation that I look terrible. Let me get back in the house. And then that's what they do. So another thing that makes it worse is that isolation, because BDD is trying to convince you that you're not even worthy of human connection.
Yeah.
So if because of your fear of going out because of misreading faces or assuming people are whispering or taking special notice, which people with BDD do, personification, this belief that people are taking special notice, that isolation occurs, and then it reinforces, well, Chris, you don't have a partner. Chris, you don't have friends. Chris, you don't have a job. It's because you look terrible. The disorder never gets blamed, of course. Like, hey, because of BDD, I don't leave the house. So one thing I'm talking to clients all about is that the goal of treatment is to get connection. We got to get you back into school or work or dating or friends or volunteering or at family events, because people with BDD tend to isolate themselves, which makes it worse because now they're just alone with their thoughts. And if BDD is dominating those thoughts, that becomes the problem.
Right. And as they have more and more experiences meeting with people, they get to learn and experience that connection and feeling seen and accepted, which can help them go in the better direction, which it's hard to do, but it's doable. Are there any other things that make it worse?
Yeah, I mean, I would say that some things that I see clients with BDD do is they actually end up getting a job at a place that they can get sort of like free Botox and free teeth bleaching or whatever it is, right? So they end up getting a job in the field because BDD is so drawn to that. So I've had clients that have worked for modeling agencies or have worked for med spas, and that whole culture, unfortunately, is looks
Yeah.
24/7, and they have access to things. They're, watching models not eating and starving themselves and then getting ideas about that, or they're watching people get now on, as a lot of clients are getting on things like Ozempic when they don't need it. So they're taking it, it's not a health related factor, but they're doing it because in BDD, it may not be always about weight loss, but a lot of people think their face shape is too big
Yeah.
for their body. So if I lose weight drastically, my face will finally look decent. Or, it's more emphasized that my body's not even when I'm heavier. So if I lose weight, it'll look more up and down, which people won't notice that it's not symmetrical. So that's what I think, the drugs that are coming out and helping people with diabetes, clients with BDD are unfortunately using it when they don't need it because there's not a lot of regulation, and that's making it worse. So I always tell my clients, if they're working at a dermatology office, a med spa, in a field that's, has an aspect of superficiality, I'm not going to tell you what to do, but you have to be mentally strong working there because you're going to get a lot of messaging that's just going to feed the disorder.
Oh, for sure. I remember in my eating disorder, I worked in a gym, which is 360 degrees of mirrors, and I knew I would not recover staying in that environment. A big part of the reason I became a therapist was because I knew I could no longer continue the work that I was doing in an environment that was going to have reflective surfaces all around. I think it's true too of a lot, since I was just thinking a lot of clients really loved COVID because they got to wear a mask, and they still are wearing masks in some cases under the lens of, I've even had clients admit they lie and tell people they're immunocompromised so that they can continue to wear masks, school, to work, social events, on airplanes. And it's okay if you want to wear a mask. I'm not saying that's wrong, but they then identified that was them actually masking their
Yeah.
perceived flaw.
Absolutely. I always tell clients, let's look at the motive of behavior.
Yeah.
There's some people that are still wearing masks for health reasons and through their doctor's orders. And there's clients that wear masks because it gets to cover the lower half of their face that they may not like. So I'm always asking clients, I'll have clients that say, oh, I love wearing hoodies. I'm like, it's 95 degrees out there. I love a good hoodie. I probably own more hoodies than people always see me in suits on these things. I'm like, I don't wear this on a Tuesday, right? I have hoodies. I love my Vans hoodies. They're comfortable. I grew up wearing hoodies, but you're not going to wear a hoodie in a 95-degree weather, but people wear it to cover up because they don't think their breasts are even, or for men, they might think that their chest is uneven, or they feel too small, some muscle dysmorphia, so they wear this baggy sweater to look larger. So a lot of it is about motive behind it. Why are you doing the behavior? Because all it's doing is reinforcing something's wrong. And when they feel relief by covering up, let's say wearing a mask or a baggy hoodie, the messaging that they're learning is the only way I can feel any sense of comfort is if people can't see the flaws that I can see when I'm not camouflaging or covering up.
Yeah. And you bring up a good point, and I know you had mentioned before that it's often from the neck up, but I want to also say a significant amount of clients who have BDD about their private areas, the size of their penis, their labia, like it can attack any part of your body. And it doesn't have to be like, oh, I don't like my entire body. It often will just pick one very annoying part and they focus on that so much. So I just wanted to sort of normalize that for folks. If you are, again, it adds a layer of shame if you have this preoccupation with, again, a sexual part of your body or a part that you wouldn't usually show somebody.
Yeah, I think the reason we always say neck up is not because that's, the only part of the body that gets affected. I think just sometimes because of eating disorders and BDD get confused.
Yeah.
But like you said, BDD absolutely attacks parts of the body from the neck down, including sexual parts, like you said. A lot of men, feel like, do I have breasts, right? Do I have gyno? The size and shape of nipples is a big one. Evenness of breasts, evenness of chest, sexual body parts, right? Like I think it looks too big or too wide or too small. My butt, is too flabby. It kind of goes down. So I think what's hard is BDD is already difficult to talk about. A lot of people don't want to open up to someone because naturally, if somebody's saying, I think this thing is odd looking, our eyes go straight to it. So they're like, great, they're going to confirm what I feared this whole time. But how do you talk to somebody about your private parts? And then, like I said, clients will ask their partners. Their partners are, of course, going to say they like it. That's why they're in a relationship with them. One of the reasons they think they're just lying. And then, unfortunately, I've had people kind of notice that as a weak spot. I've had some clients where their exes, after they break up and it's a nasty breakup, the ex will text and say, actually, it was gross looking, or it was disgusting. And I held my nose the whole time we were in it and just ignore it. I mean, it's just horrible what happened. So I've noticed that clients, it takes them a while to be comfortable enough with a BDD specialist to open up and share that their sexual or body parts are the things that they're focused on.
Yeah. Yeah. So what can make it better? Let's go there. And we can maybe as we go, you can think of other things. Where are we going from here? Like, is there hope? Is there things to make it better? What does that look like? Do you want to share?
Yeah, I'm absolutely. I mean, one thing that I'm really happy about is that there is absolutely frontline evidence-based treatment for body dysmorphic disorder, and it works. I love presenting with people like Catherine Phillips and Sabine Wilhelm because they do a lot of research. There's also, I'm gonna butcher his name, so I won't even pretend to say it, but there's a researcher out in Sweden who's done a lot of research on people getting better. So people do get better. And in fact, sometimes, it's impressive the numbers of people that get help. So what makes it better is finding somebody that absolutely understands the disorder and the treatment and getting a proper diagnosis. So that's really important because there are a lot of disorders that can appear the same. I know we're doing a podcast on that, so I won't spend any time on that for this conversation, but you want to make sure that the person who's providing the treatment understands the condition so they can really make sure that you're getting the right treatment for the condition. With that said, I mean, when you get a really good dose of education, cognitive behavioral therapy, acceptance and commitment therapy, exposure response prevention, you're addressing shame through things like self-compassion, and you're looking if there is any trauma, is there any history of bullying, are there these kind of things that have really, really created sort of a bruise on self-esteem and affected somebody's ability to accept affection and their attachment. So when you get a full kind of quote unquote dose, like we talk about in this training that we did together of BDD treatment, people do get better. And so that's what I always tell people is you have to find the right diagnosis and the right treatment.
One of the things I loved as I sat across from you and you recorded like a oh my gosh, like a machine, was how I have consulted with clinicians who, because BDD is under this umbrella of an obsessive compulsive related disorder, they've come to me in a consultation and will say, I know they had a fear that their nose was big or long or whatever. So I just exposed them to it by making it longer or writing scripts. And I used all of the ERP that I would usually use with OCD. And, it didn't hit the spot. And I loved as you were doing the training is we're incorporating CBT and ERP, but you also include things like perceptual retraining. And we use the ACT work and we talked about motivation. And that's why I love the way that you present this. So can you share with us the ERP, how it may look different for folks with BDD?
Yeah, to take a quick step back, when we were talking about what makes it worse on the clinician side, if you treat BDD like OCD about appearance, your client will not only not get better, but may be harmed.
Mm.
And I think one of the things that breaks my heart, and it's like, I don't know how many times I can say it without seeming obsessive and following people on the internet, but I do see people that are claiming to know body dysmorphic disorder, pretending to be leaders in the field, and we have great leaders. Actually, it was funny. I was thinking about it the other day. Outside of Scott Granite and Jamie Fuser, most of the leaders are women. I was like, go power. They're doing incredible work for us. I love Fugans, Kathy and Sabine and Robin Stern. But when we take OCD treatment and just change it to BDD and just change a few words, it's not only an incomplete treatment, but it's not going to be helpful. So some of the things that I unfortunately have seen clinicians do when they treat it through ERP like OCD is they've had a client sit there and write, I'm ugly, I'm ugly, I'm ugly. I need to accept that I'm ugly. I've had clinicians kind of have them use filters that make their nose look even bigger and stare at that. I've had clinicians have somebody go out and kind of accentuate certain flaws that they think they have. And the reason that doesn't work is because the person already thinks that about themselves. So you're almost kind of reinforcing this distortive thinking and this distortion in appearance. So if they're already seeing themselves incorrectly, why would we then distort the appearance even more when what we're trying to do is the opposite and pull them back in and let them see themselves correctly through perceptual retraining, which is something you don't even do with OCD. So it's a whole element of treatment that doesn't even get done in OCD. And so acceptance of being ugly or unworthy and, people are already, it's that ego-syntonic component. They already think of themselves like that. It would be the same if you're working with a client with depression and you're having them write out, I am worthless and nobody cares about my existence 100 times. It's the opposite of what we need. So with treatment, it is a much more CBT treatment, first of all, because you're trying to get the client to start to see, how did I get here? How is my distorted thinking influencing the way that I function? But when you ask about the ERP, the way that I look at ERP for BDD is we're trying to get the client back into their life. So their quote unquote exposures might look something like, hey, I normally order everything through DoorDash. I'm going to start going into the place and order and maybe take the food to go.
Yes.
And I'm going to work up to ordering and then staying in, because part of what the treatment is showing them is, look, if you really do look as disfigured and deformed as you think, how come you go into Chipotle, you're getting treated with respect? Well, maybe Chipotle is a good. Yeah. I'm like, are you sponsored by Chipotle? I don't want to ruin your sponsorship. But every time I go into Chipotle, I look like I'm bothering them. They're like, and I'm like, you don't close for another 2 hours. Calm down, sir. Right? Please just help me with my burrito. But in all seriousness, right? Like, how come the workers are treating me with respect?
Yeah.
How come they seem very unbothered or unconvinced to even look up at me? How come when I'm walking out, no kids that are very blunt are shouting something like, Mommy, he looks weird? So it starts to sort of pull apart BDD's argument.
Yes.
And as people make connections, even if it's just through getting to know the barista at their local coffee shop, it starts to send a new signal to them. And I think of the treatment as a teaching tool. It starts to teach them, wait a second, I do belong in society. I do belong in this way. Also, we're doing a lot of response prevention. So I sit with clients, let's look at who you're following on social media. Everything you're following is a plastic surgeon, models, etc. Who would you follow if BDD wasn't even part of your life? Let's get back to that. Yeah. So the treatment, for me, how I think of ERP is once the client's really understood the disorder, is perceiving themselves and not comparison. That's a big part of treatment too, but they're perceiving themselves better. They're not comparing. And then they have the cognitive stronghold that they're starting to really be able to perceive their situations different mentally. Then once they go into the outside world, it's not about like exposing them to things they hate. They've already been doing that to themselves before seeing you. It's getting them reconnected in life. And it's addressing any of those things, like I said, the bullying or the shame or the, any kind of trauma and stuff that they have, just making them a whole person. So it's a very more complicated, it's much more extensive, and it's very different than OCD. So that's the biggest thing,
Yeah.
and why I was excited for you to ask me to do this training is I just want clinicians to know that you have some foundations that will be helpful to treat BDD, but you got to make some drastic difference and see the disorder in a different way than OCD.
Yeah. And that's why I loved learning from you as well, is because it is a very holistic approach. You're looking at more than just the safety behaviors or compulsions that they're doing. What you're talking about, the way you talk to yourself, the way you think about things, the perceptual retraining was amazing. So because we rented a hotel and we were doing it recorded, you took me into the bathroom and walked me through exactly what that would look like how you would do it. And do you want to share quickly what that looks like, and a little more about that? Because I think that's an area that a lot of clinicians don't even know exists.
Well, what I loved about what we did is so many. I'm not even kidding, Kim. The number one thing people ask me all the time is like, "Is there a video of people doing perceptual training?" I'm like, "There is now." Kim is my, test dummy and
Yeah.
my client. The idea behind perceptual retraining is if you're treating BDD, ask your clients how they see themselves,
Yes.
right? So some people go to another extreme and don't even look at themselves, but typically people do, and they do it in a way that's compulsive. So the idea behind perceptual training is we're reteaching somebody with BDD how to see themselves in the mirror or pictures or videos the same way that other people see them. So let's say I'm going to start with mirror retraining. What I'm going to ask the client to do is, hey, we're going to stand in a mirror and we're going to do it a little bit differently. So instead of getting really, really close up or using a magnifying mirror, we're going to use a traditional mirror. I want you to be an arm's length away because most of the time on a crowded subway, most people are at least an arm's length away from you, like a
Yes.
comfortable distance. What I want you to do is practice when you see your reflection, going straight to comfortable eye contact. There's almost like a triangle where our eyes and our upper noses, and that's typically where we look when we're speaking to somebody else. I want that to be the first place you go when you look in a mirror. Why? Because if you notice your clients, when they look in the mirror, people with BDD, they go straight to the part that they don't like. So they'll stand up, they'll look in a mirror, and they'll go straight to their thighs if it's that. They'll go straight to their neck if they think that it's their neck, forehead if it's their hairline. So they're going to practice making that comfortable eye contact, and then they're going to practice seeing their whole self. I call it like zooming out, because the research shows they zoom in, we got to zoom out. Then what I'm wanting them to do, which is entirely different than they normally do, is to describe to me, the clinician. I want you to describe yourself, the client, in the mirror in an objective way.
Yes.
So this has to be something that if we had 100 people in the room, they would agree to your observation. So I typically say, hey, think of it as almost like if you've ever seen Law and Order, they ask the people when they're doing the police sketch, they're not saying like, ooh, she was voluptuous and I loved her upper lips, right? They're just giving you generic,
Yes.
like she had red hair, it was, down to her shoulders. So the client starts to describe themselves objectively while, from top to bottom, but they're only briefly staying on a body part. We're not teaching them to spend a lot of time in the mirror or to fixate. They're already doing that, right?
Mhm.
So what they're learning from this perceptual retraining is how to be objective versus judgmental and subjective, how to be an arm's length in a mirror, how to start with their eye contact instead of fixating on the part of their body they don't like, and then lastly, how to see themselves holistically. They practice that if they see videos of themselves, especially younger clients that are TikToking everything. Also, in pictures, not zooming in on pictures, but seeing the whole self. And especially in pictures, I'm like, tell me what's going on in the picture. Half of the time the client doesn't even notice the other things in the picture because they're so focused on how they look. So perceptual training is teaching the client to start to see themselves the same way everybody else sees them and the same way everybody else sees themselves. So it's a very effective tool, and it's become even more advanced. Fugan Ezeroglu released a book, and there's also really good some worksheets out of Australia. to really start to teach clients even attention retraining. So we're noticing that clients throughout school, I'm working with a young client right now, and she's like, at school, all I do is sit there and think about my appearance. So it's being able to start to focus outward, become mindful, use meditation, be able to think of other things. So not only is somebody looking at themselves perceptually different, but they're thinking about other things instead of their appearance, so that appearance isn't the only conversation in their head all day, all long.
Amazing. Now, before I know we're going to take respect of your time, but there's one thing that I want to make sure we don't forget to talk about. So these are all like treatments that are really effective. What role does medication play in treatment as well? Because I know in the courses and in the work you do and in the books that you've mentioned, we're talking a lot about these like modalities and therapeutic techniques. Do people with BDD need to be on medication as well? Or what is the research on that?
I would say with body dysmorphic disorder, yes, it is more needed than even in OCD.
Yeah.
And I always remind clients I'm not a psychiatrist. I'm also not a meds pusher. I'm not anti-meds. I took medication for BDD and it really helped my treatment, but I think it's an individual case. However, if you are experiencing a moderate to severe case of BDD, especially if it's to the point that you're struggling to do daily functioning, having a conversation with a psychiatrist about medication is pretty important.
Yeah.
We've been talking about Dr. Catherine Phillips. We've been talking about the broken mirror. She's a psychiatrist. She writes a lot about the dosaging, but medication can really help with insight. And I think that's one of the things that people with BDD often have is low insight about the disorder. So medication can have them having better insight. Just like OCD, SSRIs are front line. So these are things like Prozac and Luvox, and Lexapro and others. And we need a higher dose than somebody who's going in for depression and anxiety. So what I tell everybody is I understand, and I think what's a unique challenge, Kim, that I don't think a lot of OCD therapists recognize in BDD is a lot of times the reason that people are afraid to get on medication, they're afraid it's going to affect their appearance. I didn't want to get on medication because I thought it was going to make me break out.
Yeah.
I had no reason to think that, but I was just in a hyper vigilant state of fear of having acne. But clients a lot of times are afraid of weight gain
Yeah.
or weight loss because they think it'll affect their appearance. Breaking out, yellowing of teeth. What if hair loss? What if it makes me look different? So what I always tell people is find a prescriber you trust.
Yep.
Go in with questions. Ask those questions. Let's not get reassurance, but let's ask those general questions and learn how medication can help. Because I will say for a lot of clients with BDD, they do need medication that helps with insight. Does not mean that people can't get better without it,
Yeah.
but it may be a very advantageous tool in your recovery.
Amazing. I agree. Thank you so much for that. Okay. The good news is you and I are going to do a backup following episode talking about how to differentiate between BDD and body image issues and eating disorders and OCD so that people, if they're having still questions about which is which, you can follow up with that episode. For right now, for those of you listening, do go head over to CBT School. You can go to cbtschool.com/treat BDD. That is the course for clinician. And you can go to cbtschool.com/your BDD toolkit if you are someone who has BDD and you're wanting to learn exactly how Chris and myself would treat the condition if you were our client. So thank you, Chris, for being here. Your knowledge is so impressive. Thank you so much for your time.
Well, thanks for having me. Like I said, I'm excited what you're doing for clinicians, giving them access to evidence-based treatment. And thank you for having this podcast. I always hope that more and more people learn about BDD because so many people are struggling. And so many clinicians have their best interest, but just need to understand how to treat them. So thank you for everything you're doing for our community. Really appreciate it.
And if you want to get in touch with Chris, do check the show notes and we will have links to where you can work with Chris and everything there. For also, one thing I forgot to say is we are CAU approved by NBCC. And so our clinician courses you can get your continuing education units by taking this course as well. Thank you, Chris.
Thank you so much for having me. It's always an honor.